Good morning. My name's Namali Stone, and I feel so privileged to have some opportunity to talk with you this morning. I lead some of the prevention and response work for long-term care in our division, and really want to thank Dr. Bell and all of our NHSN colleagues for incorporating time for for our team to be involved with this training, because at the end of the day, and I know you've heard Angela and others echo, that surveillance is the data that helps us drive our prevention programs. And, and at the end of the day, the most important marriage between surveillance and prevention is making positive changes for our residents. Every piece of data that you collect is informing improvements in their care. So I just wanted to take a few minutes to talk about ways that we can continue to support you and drive some of the opportunities to improve that you are already putting into place. And I think it's also an opportunity for us across the board to acknowledge our gratitude for your commitment to this work and taking the time out of your schedules to be here. Those of you who are in the room and all of you who are streaming this live or who will take time to come back to these videos and watch them, we want to really appreciate that time and commitment to resident quality, because we know that you're incredibly busy, and this is a departure that takes away from what you are doing in your facilities. And so thank you for your organizations and your commitment. When I was thinking about this presentation, I realized that you all are the solution to ways that we can overcome some of the many barriers that we face and that you face every day in your facilities. And as the role of infection prevention becomes more and more acknowledged and important, we still have to be mindful that there's so much yet to overcome. In a lot of the feedback that we receive from you about having enough resource and time being the most important resource, because you have other responsibilities in your facility. You may not have as much time as you'd like to go seek out the kind of training and education that you would like to inform your practices. And so again, how critically valuable it's been for us to have you with us over the last 2.5 days. Infection prevention is at the heart, I think, of a lot of resident quality issues, but there are other activities and quality focus areas going on in your facilities. And we know those competing priorities can take your time away. And it can also take away the time of your frontline staff and your clinicians and your leadership, and keeping them invested in your infection prevention program activities and having the empowerment to work to implement change. These are all very real barriers that we are aware of and recognize. And that is why I think it's even more important for us to thank you for what you have already done and what you will continue to do, because this is such hard work and yet brings such tremendous value to the residents and the families we serve. So acknowledging that, I thought, well, how am I going to talk about capacity and where can I turn to think about examples of success? And so I took a moment to step back and think, well, what all has been happening across the country over the last almost 10 years, but at least the last 7 since NHSN first got launched for long-term care in 2012. And I was kind of staggered by just how much work and how many initiatives have rolled out in a relatively short period of time. So we had NHSN released, and then shortly thereafter, the following spring, the Department of Health and Human Services put out a national action plan chapter focused on long-term care. And they actually identified the importance of NHSN as a mechanism for understanding the burden of critical infections like Clostridioides difficile infection and urinary tract infections and the impact that they have on nursing home residents, and made engagement in NHSN one of the priorities. Shortly thereafter, there was a large resident safety collaborative that was launched by the Agency for Healthcare Research and Quality that was focused on reduction of catheter-associated urinary tract infections. And that project, which I'll share a little bit about with you in a few minutes, was one of the national opportunities for nursing homes to get involved with local quality improvement organizations and organizational leaders in their state to implement some of these resources and direct their activities around CAUTI prevention. You've heard already about the CDC funding that was related to Ebola that drove infection control assessments and response work by many of our state and local health departments across the country. And along the way, we had more guidance coming out directed at nursing home specific issues like how do we tailor the core elements for antibiotic stewardship to meet the needs of practitioners in nursing homes. And I really appreciate Sarah's presentation and all of the feedback and questions that you all raised during that presentation, because it shows us that we still have opportunity and more work to do to help you implement some of these changes. You're all intimately aware of the requirements for participation that came the following year and really brought antibiotic stewardship front and center in the midst of a lot of additional changes to the infection prevention program expectations. And I know several of you in the room and probably online as well were involved with the Quality Improvement Initiative on C. difficile reporting into NHSN and prevention. And so let's look at some of those initiatives in a little bit more depth and see if we can learn from what was accomplished. I'm going to start with the AHRQ CAUTI prevention work. And one of the things that was exciting was this initiative utilized the NHSN surveillance criteria for catheter-associated urinary tract infections and tracked rates in the participating facilities using those surveillance criteria. And that was a way to bring more awareness to the NHSN definitions and help facilities learn how to do the surveillance in a way to operationalize that. In addition, they implemented several clinical interventions and some cultural interventions too, because there's recognition that you not only need the technical information about infection prevention practices in general terms, how we incorporate and improve hand hygiene at the bedside, how we improve the way we use gowns and gloves when we're taking care of our residents, and especially those residents who may have increased risk for antibiotic-resistant organisms. How do we engage in better forms of education, not just for those leading infection prevention, but also for frontline nursing staff and nursing assistants who are doing a lot of the hands-on care? And then what are some specific interventions that'll help target and reduce the incidence of catheter-associated urinary tract infections? And then they also looked at what is the culture in the building? How do we enhance and engage leadership and concepts like communication and resident safety culture in a way that can facilitate and sustain some of the technical changes in infection prevention practice changes? And the way that this collaborative rolled out was also an interesting model. There was a national group of experts that were developing and coordinating the entire program, but also developing a lot of the initial training resources and materials that would help support education and program implementation. But then there was another layer of partners that were brought in at the state and regional level to help with facility recruitment and to be more accessible coaches and cheerleaders and resources that would help facilities to overcome implementation concerns or barriers, and also to be a direct channel to communicate back if there were more needs that weren't being met by the national project group. And then there was a commitment made by every facility that also got involved in this program, and they made some commitments to the data collection, to the communication and education of their staff, to participating in some of the ongoing coaching work that was facilitated by both the organizational level and the national level teams, and really making this commitment to CAUTI prevention. Was anybody here involved in this by any chance? So a couple of people, but I think for those of you who didn't have the opportunity when it was happening to occur, I do want you to be aware there's tremendous resources that came out of this work that's still available, all free, all online. The links at the bottom will take you to the implementation guide and some of the educational bundles. There's training videos, there's activities that are directed for both the infection prevention staff, but also for frontline staff to help you work on these issues with your teams, and a lot of materials to help support not only your data collection from a surveillance perspective, but also an evaluation of what happened with this particular resident, what were the contributing factors, were there opportunities to recognize this event or change the possibility of this event happening based on best practices with catheter maintenance. And so a tremendous amount of information, education, and resource still available. And this is some information from a qualitative evaluation of the experience. And this team went back and talked to some of the organizational leaders and some of the facility leaders and said, tell us what happened during your participation and what did you see occurring in some of the facilities. And these were some of the comments and the perceptions that were shared. In the buildings, there was more awareness of the opportunity to improve the management, the recognition of catheter-associated urinary tract infections, and to recognize there were a lot of prevention opportunities. For example, there was improved evaluation of catheter need and removal. There was a higher level of comfort among frontline staff at recognizing and communicating symptoms earlier when they had concerns. But they also started to become much more confident and comfortable talking to clinicians about the ongoing need for the device, whether urine culture was appropriate, and whether the use of antibiotics was indicated. So the kind of content that was available and the resources really empowered the frontline staff in a meaningful way. It allowed these facilities to modify some of their practices and really expand their educational activities. And they saw better collection of urine cultures, more proactive improvements in the way catheters were handled, and they found alternatives to indwelling urinary catheters that allowed them to remove some of those devices. The programs were able to start sustaining some of these practices themselves by doing monitoring and auditive practices and watching for and evaluating the competency of frontline staff as they were inserting and handling devices. And providing that kind of feedback in real time enabled on-the-spot education. And some of the homes actually recognized that they could take this same information and share it not just with the frontline nursing staff, but across all the different levels of frontline staff, because their comment was all of our staff have a role to play in prevention, which I think is such a great insight and such an important part of thinking about the team that can support you in your infection prevention work. And they also saw the opportunity to take this information, especially around the appropriateness of urine testing and the appropriateness of initiating antibiotics to start some of those important conversations with residents and families. So let's look at a little bit of what we learned from our experience with the infection control assessment work, which I know you've heard already before, so I won't belabor exactly the details of the evaluation. However, I will say that for a lot of different infection prevention practices, there was a discussion about not just policies, but how do you incorporate those policies through training, and how do you sustain and reinforce those practices by that ongoing auditing and monitoring of practice and feedback to frontline staff on their adherence. And what is the infrastructure for those frontline staff to be successful at following practices in terms of supplies and accessibility? And we had 49 health departments at state and local levels working with almost 2,400 nursing homes. And a lot of the assessment work, I want to make the point, was happening in 2016 and 2017, which is just on the cusp of when the proposed requirements had been posted and then finalized, including information about antibiotic stewardship and the role for training for those individuals who are overseeing infection prevention programs. And so I think knowing the timing and understanding the context of when this work is being done is important when we look at what are some of the findings. Almost all of our facilities out there have identified an individual, many of you are in the room with us today, who are coordinating your programs and responsible for your programs. And when you look at how much time was available, it's not a lot of time. About 15 hours per week was the average time dedicated to infection prevention. People, about half had received training, and I know if we went back and did these assessments now, a much larger proportion of people will have received infection prevention training. All of you in the room again and online with us are proactively taking advantage of these educational resources. Policies and practice standards are often in place, and having a system, a committee to support the review and implementation is also in place. But there are still some opportunities to strengthen the implementation of those practices. And again, I think this is not novel information. You've heard that there's a lot of variability in how much support is available across the country for infection prevention programs in nursing homes. I think you, in your own roles, probably experience that variability as priorities ebb and flow and resources ebb and flow. And there's opportunity still to provide more dedicated time for you to do your work. And I think there was a lot of discussion about how programs can help support the practice among frontline staff in their adherence to infection prevention practices through not just having those policies and procedures, but looking at them and monitoring in real time. But I think also what our programs and health departments and what we have gained from this work is also so critically important. The relationships that have been established have improved communication between providers and health department frontline staff. And I think especially for many of our states that didn't have as much opportunity to work directly with nursing homes, to walk through them, to see what your experience is day in and day out, really open their eyes to understanding the differences in what your needs might be compared to other healthcare settings. And it really was a positive learning for both groups. There was a lot of immediate on-site education and a lot of resources that were shared, along with ongoing follow-up to help providers with their decision-making in terms of prioritizing areas to focus on in their improvement work. And this leads so directly into your QAPI work and your risk assessment work in terms of identifying opportunities for improvement. And another initiative that led to the development of a lot more training and resources at the state and local level. And the last initiative and large-scale collaboration I want to highlight is another one that we've talked a lot about already, and that is the work that the Quality Improvement Network, Quality Improvement Organizations, working with CMS launched to promote C. difficile reporting in NHSN. The structure of this initiative was similar to the AHRQ program in that there was a national team working to support the QIOs and the providers in the field, and a lot of coordination in the training resources to support NHSN involvement, as well as C. difficile prevention and antibiotic stewardship, was made available. And I hope that all of you have availed yourselves of these resources as well, because there again is a lot of free valuable training material that is directed at frontline staff and to help you as infection preventionists bring information back in a way that is relevant and easy for your frontline to utilize. We know that there's tremendous time crunch for everyone, and so having bite-sized pieces of information, short videos, has been an incredible value to helping support your staff education work. And so what have we learned from that experience? And there have been several publications coming out about the expansion of NHSN and what are we learning from the experience of driving more providers toward NHSN. This is just one that looked at facilitated interview with frontline staff from a group of nursing homes, many of whom were enrolled. In fact, 12 of the 14 facilities where staff were interviewed had been involved in NHSN in some way. Either they had enrolled in the past but were no longer using it, or they were enrolled and reporting somewhat, occasionally putting data in. There were some brand new, had just enrolled but hadn't necessarily started reporting, and 2 facilities had not yet been enrolled in NHSN. These structured discussions captured a lot of information about the people who were being interviewed and their facilities, but they also looked at, were you involved with state initiatives? How familiar were these particular staff at these homes with NHSN or their facilities' use of NHSN? And what were some of the perceived benefits and challenges to using NHSN from getting enrolled and reporting? And when you look at the types of people who were involved in providing this feedback, the vast majority were facility administrators or had a leadership role, directors of nursing, or clinical nursing staff. And most of the folks had fairly long tenures in the facility where they were working. And they, on average, had about a quarter of their time, roughly 10 hours per week, that they were dedicating to infection prevention work. So they tried to get facilities from different parts of the country. They tried to, and you can see a lot more of the facilities, about 40% were East Coast. There was a bit of a diversity in terms of the types of facilities, although about 40% were not-for-profit. Only 15% or 2 of the facilities hospital-based. And these are small numbers, right? So we know that they may not represent all of the experiences out there, but I'm going to share some of the feedback and themes that came out of it, and I'd love to hear from your perspective if you agree with some of the things that were said. There were sort of 6 big buckets of feedback themes that came out of these interviews: the benefits of NHSN, the importance of having external support, and that really got at facilities that were taking advantage of being involved in quality improvement collaboratives, federal resources, the discussion about if there might be mandates or reporting initiatives in the future. At the homes, the importance of a champion, the need for a champion to really own and have the opportunity to lead this kind of work. There was a lot about what were some of the barriers to enrollment, what is the perception of the value of the data, and some of the themes that came out around that had to do with risk adjustment, and data integrity. So let's look at some of the comments that came out around these themes. So the process of NHSN reporting was perceived to, by itself, improve awareness about infection prevention. Being asked to be involved in this collaborative or to get involved in this system not only triggered value for the person doing it, but actually gave the whole leadership of the building some awareness, and also helped drive some discussions with frontline staff. I'm seeing a few people nodding. Hopefully, those of you who have been involved in this work and experienced this have similar have seen some of the similar benefit. There was a perception that quality improvement more broadly for this setting could be prompted and expanded by sharing data and working with the quality improvement organizations and with public health partners to be involved in NHSN reporting could also help them better target and support you. And I think a lot of that feedback came out of programs that were working directly with state programs, and seeing how that relationship allowed NHSN data to become more meaningful locally and more broadly. Benchmarking would be a strategy that NHSN could offer for encouraging best practices, having a sense of where my facility looks similar to other facilities like me. And that was a theme that came out of one of the perceived benefits, not just from facilities that were enrolled in NHSN, but even from those that were not enrolled. A tremendous amount of value for the QuinnQIO support that was provided to providers in getting involved in this work, and the incredible value of learning collaboratives. And that's not just true for this initiative, but even the CAUTI prevention work and the opportunities working with state health departments to be involved in infection prevention learning collaboratives. There's a theme about being able to share my experience with other providers that are working on similar activities and learn from one another. And that really was a great example of the value of the external partnerships that helped to support this activity. The need for a champion, I don't think we can overstate this, that all of you are your infection prevention champions, and your commitment and passion and the motivation that you bring to this work is what really sustains and motivates your colleagues. And this came out in several comments about the success of these facilities activities were really in the hands of people who were passionate about what they were doing. And among facilities that weren't enrolled, recognition that this kind of work really needs that dedicated time and that colleague who has the opportunity to become an expert in this work. But I think we also have to recognize there's some challenges and balance the benefits and opportunities with looking at where can we still do better in supporting the investment of time with the value that comes out of it. So one of the themes around barriers was there was a lot of time and resource taken to enroll, and it took us a while to see what the benefit was. And I think this is getting at something that all of you who have made this commitment to be involved in NHSN, and for those of you who are considering it, we've taken to heart. And I hope over the last few days you've recognized that having things like the dashboard to bring your data immediately front and center and to make data more accessible. I hope those that took advantage of the learning sessions in the lab were able to see how to access reports and take more out of the work that you're doing and the hours of investment that are being made to put the data in, because we all recognize that that is a critically important part of making NHSN valuable to you. So there were clearly issues related to those resource constraints. And then there's a lot of discussion about how do we ensure, especially as we move forward, that the feedback that we can get from our data is accurate, and that as we think about how data are used on a larger scale, that there is accuracy and integrity in the data so that there is a fair comparison being made. And we know that in any system, not just NHSN, but across the board, we have to be thoughtful about how we put in information in order to ensure that the data are valid and accurate. But this is why these conversations with you and the opportunity to have you with us to talk about your experiences is so critically important. The questions that you ask really inform how we can adapt and message and educate about how data are used and how we strive to make sure that the definitions align with best evidence and work toward better consistency across the industry. I think that the balance of this experience and what we are learning from the work that all of you are doing makes our systems better. And that is why I think the kind of accomplishments that have been made are so important to celebrate. So for all of this, what have we gained from these initiatives? Well, in the cohort of nursing homes, several hundred across the country that worked on the CAUTI prevention initiative, there was an over 50% reduction in CAUTI rates. And a lot of those came from those very at the bedside implementation practices that you saw. Our state and local health departments across the nation have supported over 2,000 facilities in looking at and thinking about their infection prevention programs and offered real-time on-site technical support for improvements. And I know that if we were able to go back today, the strength in those programs and the changes that have been made as a result of those discussions would show tremendous advancements. And I think this is capacity at our state health department level that continues to be in place. And so we really do encourage you to take advantage of those resources and reach out, because there's still a lot of programs that are doing infection control assessments and want to make themselves available to you. And as a result of the initiatives to increase engagement in NHSN, over 3,000 facilities are now involved in the system, and more than 2,000 have been reporting CDI data for a couple of years. And that is going to be the data we can use to answer some of the questions about risk adjustment and data validity. And this gives us the capacity to make the data more meaningful to you and your facility's experience, and allow us to create some of that context for how different providers have different experiences with these infections. So I hope you are hearing our gratitude for the amount of time and investment you've made, because this is how we meaningfully will improve our system and also the opportunity to support your programs moving forward. So I think I've covered a lot of what came out of those initiatives and the themes that we took away from what we learned working with all of you over these years. But I think the value of all of you is so important. I'm going to keep saying it over and over again, because the infection preventionist, the person responsible for your programs, is the starting point of success and resident safety. But you are not an island, and you should not be alone in your efforts. There needs to be that leadership and staff engagement as well. And I think these initiatives really showed how providing that infrastructure for improving education, for bringing new initiatives in a way that engaged frontline staff, really brought an awareness and drove a recognition of your programs across your organizations. And the model of national projects with local partners at the state and local level to support them also, I think, is an important recognition of the value that local solutions and having resources right at your fingertips to help brings to your success. And it allows a lot of providers to sustain their engagement in the midst of all of those competing priorities. So these data are a little bit older. The survey was a few years ago, about 5 years ago, but there was almost 1,000 facilities that were sharing information about their infection prevention programs and their infrastructure, and some of the turnover and staffing challenges and resource concerns that they were experiencing. And what they did was they looked at, and you can see sort of a snapshot of some of the staffing description of programs, and some of the similarities actually of the types of people overseeing infection prevention and the years of time that they've invested in this work, from some of the other initiatives I've shared with you. But a few years ago, you can see about only 40% of individuals leading programs had training. It was up to 50% from the infection control data, the ICAR data I showed you from the state experience, and I've absolutely am certain that that number continues to go up. But the time dedicated to infection prevention remains about 10 to 15 hours on average, and most people, including many of you in the room, I know, have many other responsibilities besides infection prevention. And I think one of the other striking issues that came out a little bit here was that almost 40% had multiple individuals asked to wear the role of infection prevention coordinator in their facilities in a very short period of time. So the turnover in our infection prevention program leadership is a really important factor, and I think that may be due to being overwhelmed, being burned out, having way too many responsibilities, especially in an era where we are expanding the expectations of our programs. So for those of you who are administrative leaders, and if you're able to share this message with your administrative leaders when you go back to your facilities, to say the work you do is so critically important, and allocating that time and designating that position so you can focus on expanding your infection prevention programs is something that we strongly urge facilities to do and support. But I thought this was sort of an interesting aspect to this study. They were able to link a large proportion of the survey respondents' centers back with data from CMS on their infection control assessment, from certification reviews, and looked at the occurrence of infection control deficiency citations that were happening in the same year that the interview surveys were received. And among the group of respondents, about a little over a third had experienced an infection control citation. And so they looked at some of the factors, and this is very exploratory work. It's looking at associations, and so I consider sort of thought-provoking for us. But that among this group, the facilities where the individual overseeing infection prevention had more years of experience in the building tended to be associated with not receiving a deficiency in infection control. Individuals who had received training seemed to be protective, as well as those that had received financial support to obtain that education. And I look at those of you who are in the room with us and have been all week, and think about the investment that you and your organizations have made to being here, and want to again express how important and how grateful we are that you are here with us, because I think this is a clear demonstration of your commitment to this work. Having physician leadership involved in the infection control committee that helped guide the program. And I think in light of the conversations that were coming up during the stewardship discussion, I think this is particularly important to think about because our clinicians, our medical directors are incredibly important partners in driving antibiotic stewardship and also driving improvement in infection prevention practices. And their investment in programs is meaningful beyond just being at the committee, but it's in the way they role model, the way they follow best practices, the way they encourage their peers to be role models as well. And so I think this was an interesting finding that those facilities that had directed physician involvement and support in infection control seem to have fared better with their infection control assessment during the survey. And not surprising, I think, that when you have less turnover in your facility leadership, there's a stability that comes from that, and it may strengthen not just infection control, but other quality initiatives in a facility. It's the disruption I know that turnover can cause that can be a real challenge for sustaining improvements. So thought-provoking information, and I think compelling for us to continue to evaluate as our initiatives to increase education continue in this country, and the way that your programs are investing in infection prevention should be heralded. So I'll leave you with just a few high-level takeaways and thoughts, which is that from all of this work, I would say that infection prevention is not a single individual. It is not just a one person in the building. It is everybody's responsibility. And those themes came out of all of this work: the importance of leadership, the importance of engaging frontline staff to find those solutions across your organization, the importance of sharing the responsibility and accountability for improving practices, which I think we often don't do as well. Infection prevention is thought of as something over there that person does, and it's not built into the culture of our buildings as much as it could be. And that recognition that came out of those interviews, that everyone has a role. And so to me, these are just all of the key players that should be a part of your programs and involved and invested in the work that we're doing. The critical importance of all of you that are champions for infection prevention, and not just those leading the programs, but all of the champions in the front line as well, who are dedicating their time to obtaining education, helping you implement your surveillance activities in a way that promotes consistency, and empowering you to assess your practices, and they're helping assess the practices and identifying the barriers to those practices so that changes can be made, meaningful changes in workflow, changes in access to supplies, things that'll help adherence improve. The investment in education, I think we've said it in so many different moments in time, and your being here is clear proof of the importance that you put on availing yourself of training and education. And again, thank you for that. We've got a lot of material out there and many partners across the country who have also made infection prevention training resources and materials and courses available. So there's a whole host of opportunities, and tens of thousands of people I know have been trained in infection prevention focused on long-term care over the last few years. And it's an incredibly exciting time to see how that is going to translate to strengthening your work. Building into your existing programs and infrastructure, I think this is something that all of you already do, but it's important to remind ourselves that this is so in alignment with your QAPI initiatives, and really all of the pieces that you've been talking about: data collection, using data for action, translating that data into changes in your practice, are all so much a part of QAPI and performance improvement. And critically important, that allocation of resources to making those changes sustainable. And finally, take advantage of these programs. When there's another opportunity through the QIO program or through the State Health Department program to be involved, I hope you'll take advantage. I know many of you have already, and I hope that you have reaped the benefits that others have in terms of having access to expertise, having access to one another to learn from in shared learning collaboratives, working with your state partners to strengthen your programs and in taking advantage of them and using their resources and their supports. All of these have been what have sustained and really improved these programs. And for people who are new to infection prevention, these resources become particularly valuable. So I will stop and thank you so much for your time and your work and your commitment, and would love to hear your thoughts about this and your advice about how we can continue to support you better. Thank you.
So I just want to thank you for sharing with us the work that you have done with different collaboratives and the resulted the results of this work, like the CAUTI and CDI resources and tools that you have created. And also, I just want to emphasize with the facilities present here and also in the web stream, to go back and see who is the QIO in each of your states, because I work for a QIO and we can be of a lot of help for you. We can provide technical assistance, support, resources to help you with improving quality in your facilities. So, and I'm talking about this because when I call and I go back and work talk to different facilities, they don't know who the QIO is. And I think it's very important to start promoting us because we can be of great support for them. Thank you.
Thank you, and thank you for the work that you've done.
Any other questions?
All right. Well, thank you again.